with industry, but it mainly relates to implant development rather than arthroscopy. So as you've heard, there is an explosion in interest and uptake here, and the technique is evolving. We know it's probably less invasive than open surgery, but it's still complicated, and you saw some beautiful operations today, and there's still a learning curve. And the bit we're missing around all of this is actually the outcomes. There's actually a robust literature to tell us that actually what we're doing is sensible, it works, and it is benefiting our patients. And I can see some of you looking suspicious, but that genuinely is what we're missing at a high level. Because what we are facing is a dramatic growth in this intervention. It is attractive. You've all woken up, come here this morning, and come into this room because the concept of hip arthroscopy, and particularly the concept of hip joint preservation, and those who are pushing hip arthroscopy will one day regret not embracing the whole of hip preservation rather than just hip arthroscopy, is a very attractive one, and therefore we want to look at it. But we need to make sure that what we're doing actually works. So what I'm going to do, and I may drag on beyond the time because Victor isn't here, so hopefully we'll have got a little bit more time. I'll talk a little bit about a paper we published on the literature on labral repair, mainly because I think it illustrates the literature limitations. I can summarize that paper in 2 slides, but I'll take a few more. I'll then talk you through the outcomes that are out there for arthroscopy for FAI, and I've picked a selected literature of what I think are the better papers on that. And then I'll present a personal series, again, just to give you an idea of what is possible, and then some reflections on the end to hopefully get you thinking and open up some discussion, because you've got some very good hip arthroscopists here, and you may be able to quiz them on what happens. So this is a paper that was published last year, trying to do a quantitative synthesis of what is out there in the literature on debridement versus attachment of the labrum. And it's fascinating when you look at what is out there in the literature and try and trim out the ones that have good methodology, you end up with very few studies that actually give you useful information. So starting with 344 studies, we've ended up with 28 that the boys put together and tried to analyze. And even within that, we only got 1,609 patients. So we put that together, and what you find is that there is limited information available. So we could only identify the etiology of the problem in less than half of these, and it was an acute injury in about 1/3. In terms of symptoms, mechanical symptoms are only about 40%, and we could only identify pain location in less than 20% of the patients. So we need to do better from that point of view. What else goes with labral tears? FAI, you've heard about very eloquently this morning. Chondral lesions, of course, the two go hand in hand, as you heard, and then ligamentum teres injuries, which are something really we could debate in discussion because I'm fascinated by them. The world is divided into 2 categories: those people who talk about the ligamentum teres all the time and those who I respect. And it's really very difficult differentiating between the two. That was just to test who was awake, but never mind. So if you look at these studies, the status of the labrum is documented in detail only in 4 studies, and the location only in 11 studies. So the literature has really let us down. If we look at the outcome of debridement, you see good outcomes up to 44 months, so less than 4 years, in over 80%, but there are only 2 papers reporting the long-term outcome. If you go to the crux and try and compare repair with debridement, and bear in mind these are not PRCTs, these are just comparative groups, most of them are on the side of repair. Probably Larson's paper is the best one, but in reality there isn't any level 1 data on this because people have just moved from one technique to the next and haven't compared apples with apples, they've compared apples with oranges. So there are lots of biases in the literature out there, and that's the reason I'm talking to you about that, because everything gets published these days. There are many, many journals out there, and you have to be careful what you interpret. And if you methodologically try and identify what is out there on the labrum, it's actually very difficult because the classifications are different, the types of tears are different, the documentation in the papers are different, and the inclusion and exclusion criteria are different. We haven't done this very well. For me, the biggest differentiating factor in terms of outcome, if you're going to take nothing away from this presentation, you should take away that the level of chondral damage that you have in the hip when you start an attempt at treatment is the prime determinant of outcome. So if you're looking confused, if you're feeling tired, this is the one thing to take away from this presentation. Chondral damage is bad news and will probably lead to a poor outcome. There are lots of other factors that the papers don't consider, particularly secondary gain issues and learning curve issues, which are important. So the first thing to take away from the literature on hip arthroscopy is that higher quality data is needed. We have done ourselves no favors because we've embraced a procedure and collected a whole load of cohorts without really doing the level 1 work that we need to do. What about FAI management? That's really been around in the literature arthroscopically for more than a decade now. So some great men doing good work describing what they do. Look at the follow-up here. This is a paper from 2007, 10 months follow-up. So it's really not long enough to ever get you an arthroplasty paper published, yet for some reason we're publishing papers after hip arthroscopy at 10 months. The real gain is potentially 10, 20, 30 years. So we've got to be very careful. Tom Bird, 90% success at 1 year. It's the 10-year results that probably matter. Although admittedly, as Vikas said, we may be delaying something which would be good. Again, minimum 2-year follow-up, a little bit better. This is quite interesting from Tom Bird. The key message is at the bottom of this paper, which is 97% of those guys had articular cartilage damage by the time they came to their hip arthroscopy. So the modeling that Vikas is talking about may be important. It may be a great intervention for hip preservation, but it's when you do it and who you do it on that probably matters. Mark Philippon, interesting, very honest paper. If you do it on patients over the age of 50 years, 20% needed a rapid hip replacement. And as I'll show you from our data, it's perfectly possible that we're making some patients worse by doing this intervention. This is an interesting paper from John O'Donnell. Patients over the age of 60, mean follow-up at 30 months. I don't know if anyone on the faculty has seen the follow-up on that. I'd love to see the follow-up because I can't believe for a second that those guys had good long-term outcomes. It's a triumph of technique over reason. So are there any higher levels of evidence? There have been some attempts at systematic reviews. This is a good one from the American Journal of Sports Medicine. You've got to remember that when you have a systematic review, it's based on the quality of the underlying data. And so that really determines the quality. Here, what they've really managed to do is that report that patients' symptoms improve, but if you have more than tonus grade 1, you have worse outcomes. So chondral damage is bad. Bear that in mind. Is open surgery the gold standard, or is it arthroscopic? There's a couple of papers here, one from Brian Kelly, the other from Ben Dome, really pushing us very much towards arthroscopy, giving us better outcomes for FAI. And what causes failure? Again, the same message from a good group, methodologically sound work from Boston, looking at the literature. Chondral damage is bad news, leads to failure of hip arthroscopic intervention. In terms of quality of life, some improvements. This is sort of Villar science, just looking at cohorts and looking at scoring systems. They seem to get better in terms of quality of life. And if you look at athletes, what you find, I'm sorry, I forgot to switch the animation off here. There's a couple of papers that show a really interesting difference for me, which is that the athletes get better much more quickly than the average guy. So what tends to happen is your athlete is 2 to 3 months quicker in terms of return to sport and is more likely to get back to their pre-injury level. It's much more about the athlete wanting to get there than it is about the complete symptom relief, which doesn't necessarily happen. And I'll show you that from our series. And again, some good work from another center showing the same thing, that most of them do get back to their pre-injury level of activity, but it's much quicker and much better in terms of symptom relief in the professional than the recreational athlete. If you look overall at hip arthroscopy, which is maybe what Vikas wanted me to do, you'll see actually it's a good operation. The complication rates are pretty low, and that's probably the reason it's still growing, because the technique has been refined and you've got pretty low complication rates. I'll quickly run you through our study. This is 186 patients. We haven't published this yet because we're about to do the 5-year follow-up, and I think the trends are really quite interesting. These are highly selected patients because we'd reviewed the literature before. So there's 104 males, 82 females, and the age range is pretty wide, up to about 46, but they've all been selected so that they did not have tonus grade 2 or above when we started. So they all had symptomatic impingement. They all had 3D imaging with CT and or MRI scan, and we excluded dysplastics and excluded osteoarthritics, reiterating that trend that you heard before in the previous excellent presentations, that you need to get your patient selection right, because if you operate on the wrong patients, they would do poorly. So I want you to bear in mind that this is a highly selected population when you look at the outcomes. So we've documented lots of things here, and even though we thought we were being very, very careful, you'll see that there was grade 2 or more articular cartilage damage in almost half these patients, and significant chondrolabral delamination over 2 centimeters in 16. Those patients do incredibly badly, no matter how nicely you microfracture them. So do the patients do well? Yes, they improve their range of motion. They're mostly satisfied. Their non-arthritic hip scores improve, and they stay improved for up to 4 years unless there is chondral loss. If you look at this graph, the purple lines are the ones without chondral loss. The yellow ones are the ones with chondral loss, and you will see that as we drift from 1 year to 3 years, there is less good outcome in those with chondral damage. That's going to deteriorate significantly the 5-year mark because we have the prelim data. So if you have chondral damage by 5 years, your positive outcome is getting much worse. Likewise, UCLA scores, these guys get back to sport, as you've already heard, but even more dramatic change in activity for those who have chondral damage. It's going to get worse and worse, and those with chondral damage, you may buy them a few years, but you need to warn them that it's not a solution for life. The problem will still come back. As the others have told you, there are some complications, but they're not very common, and they're usually transient. Rearthroscopy in our hands makes very little difference. You get it right the first time, or otherwise their problems continue. But those are rearthroscopy for ones where we did the primary, and this is my worry. There are 6 conversions to arthroplasty in our series within the short term. Those are patients in whom I would bet arthroplasty would not have been necessary as quickly had we not done hip arthroscopy. You've got to be careful what you promise your patients. So they improve, some don't improve, and those are the ones with chondral damage, and some get worse, and those are the ones we need to stop ourselves from operating on. So just a word of warning at the end. These guys have done a fantastic job of giving us a great operation that works extremely well, but we've got to be careful to get patient selection right, because if we do not get patient selection right, whichever country you're in, whoever is paying for the surgery will stop paying for it if the outcomes are poor. So you really need to bear that in mind. It's happening in the UK, it will happen in North America, and will go to the rest of the world. Unless we get the indication right, the commissioners won't pay for it anymore. This is an important slide. It's familiar to all of you. What's happened in hip arthroscopy is we have lots of data at the bottom of that pyramid, and we have some attempts at synthesizing literature at the top, but we need proper level 1 data if we're really going to go forward on this, and that's really sadly lacking when you look at the literature in terms of outcomes. The last things I want you to think about is, what is it that we're aiming for when we do this procedure? The guys have shown you that we can achieve better anatomy and radiology, we can achieve some pain relief and satisfaction. We have yet to demonstrate an improvement in natural history. That's what really we have to do, and I think we need cleverer techniques like cartilage mapping to try and understand who the winners are going to be, who the losers are going to be. So patient selection is going to be very, very important in future. We've set up a registry in the UK to really try and longitudinally follow up those patients. And my last plea here is, I hope you're in the room because you're interested in hip arthroscopy. I hope that some of you are still awake. If you are still awake, the key is that you actually get robust outcome data for what you do, because if you do not, this operation will disappear. Thank you very much.